And understand that we are here between a rock and a hard place because there were such phenomenal sessions all day long. And after us is the reception. No one wants to stay beyond the time that the system is geared to be at the reception. It's beer time, right? So let's be concise. So everybody will have 5 minutes, but while you warm up for this, I just want to introduce you. The first, from my left, is Klemens. And next to him is Sören. Next to him, now you know, is Chris. And then Harrison. And Tobias. And last but not least, Harald. And look, this is a heavy-duty pedigree. Just Google them, and it's all there. I guarantee you. So while you think of what you want to say in the 5 minutes, I want to do something. I hope I'm not violating any freedom of information. But Nana, and first of all, before, where's Nana? Oh, she's busy getting ready for the next one. I wanted to thank her for inviting all of us. I think that the Charité, different Charité Summit, is a unique opportunity. I try to come every year. This is where you find people with an optimistic view of the world, and that's why we all want to be here. So I want to thank her for that. But she was kind enough to share with me at least the excerpts from a speech that Frank van Houten, chief executive of Philips, made during the World Summit, the Davos Summit. We all recognize that digital technologies are firmly embedded in our lives. The Internet of Things is becoming a reality, growing from 15 billion smart devices in 2015, at least 50 billion by 2020. It is easier than ever before to connect data-generating appliances, machine, and even complete industries in the Internet. As a result, we are also creating vast amounts of data, faster and more detailed than ever before. 90% of all data in the world today has been created in the last 2 years alone. The big data revolution has led to the emergence of the fourth industrial revolution, which is about combining connected devices with cloud computing, big data analytics, and artificial intelligence. Our critical infrastructures will become smart. He goes on to talk about the aging world population and the challenges, but then heart disease, cancer, respiratory disease, and diabetes are now killing 31 million people a year, according to World Health Organization. Healthcare costs are spiraling out of control. According to the Economist Intelligence Unit, global health spend is rising an average of 5.2% per year and is set to bust $9 trillion by 2000, this is US dollar, not Canadian, $9 trillion by 2018. This is simply unsustainable. We tonight want to help him and everybody else to address the challenges. So, to you first, and I'll stay silent, which is difficult for me.
Yes, so my name is Klemens Budde, and I'm actually a medical doctor, and we're going on rounds this morning, and my specialty is nephrology, and I'm taking care of kidney transplant patients, and this is kind of my heart and research. And basically kidney transplant patients are very specialized, they're very vulnerable, they have gotten a kidney transplant, which is really a gift from the society, and we the doctors have to take care that this gift is lasting long. However, these patients have many diseases. They have to have a high pill burden. Non-adherence is fatal because then they may lose a graft. So we have to think about how to better treat those patients. And this is a lifelong therapy just beyond the hospital. The hospital stay is only 2 weeks or 1 week, but then we have to take care of them for 20 years or 40 years. So the idea of what we have and what we are going to implement is kind of with Chris's ideas bringing forward into German practice to increase patient adherence, empowerment and so on, with just have an app for the patient, but it's not a unilateral app or so, just a unidirectional app, it's a bidirectional app. So we want to communicate with the patient and communicate the patient with us. So basically we want to expect him to get his blood pressure, his weight, temperature or whatever, and then this is put into our data system, and basically they get from us the medication plan and so on. So that's a bi-directional communication. It's kind of with a built-in WhatsApp for communication, so I can come to my appointment today, I want to come tomorrow or whatever. So this is kind of a back and forth flow, so that we are really sitting in the pocket of the patient, sitting here on the iPhone, and then the patient can communicate with us and we can communicate with the patient in a constant way, in a bi-directional way, back and forth. Of course, for example, the patient gets a new drug, and then he has to go to pharmacy, he has a long history of drug interactions or so, and he scans in the barcode. This is the idea, goes into pharmacy, scans in the barcode, and then sends us the data, and we immediately have all the data available. We have renal function, liver function, genetics, and the co-medication, and then within a second we want to send him back, okay, green, you can take the drug, on red, call your doctor, so there may be a problem. So this is one idea, having this, but the other front end is we have to deal with nephrologists outside our hospital, because we have to communicate with other doctors as well. And we want to create a platform to communicate back and forth with the kidney values, the medication, back and forth with the community doctors. So we have share one platform, all in one platform for this one single patient, so we have less drug interaction, less problems, less readmissions, and so on. So this is our vision, and we are going to implement this. And of course, I think this is also a vision for the future, that patients will have wearables, we will collect data of wearables, and as a doctor, I'm going to prescribe 1,000 feet a day or 2,000 feet a day, and then the patient, we are recording the feet, and then he's only doing 1,000 feet, and say, guy, come, you have to do 2,000 feet, and it's not about medication, it's about blood sugar control, blood pressure control, activity, and so on, and this is the vision we want to have. And then at the end of the day, I think we have a lot of data, and this data are good because they are validated by the patient, by routine clinical days care, and then these data are good for research. These data are important for health insurance companies, so we partner with the AOK here in Berlin-Brandenburg in our project. And this is good for pharma industry because they also need reliable data on routine clinical daycare. And this is our vision of the future, that we have a system which is really putting together all the pieces from existing data sources, hospital systems, general practitioner, and the patient into one system for research, and of course better patient care, because we think that research or clinical research has to be connected to better patient care, and that you have a benefit for the patient and for the doctor.
Well, thank you. To you.
So my name is Sören Eichhorst. I'm leading the Hospital Institute at McKinsey, and that's why I have a pretty fair view about the reality in German hospitals, I think, and also European hospitals. And that's why my view is maybe a bit different, because I also have to fight with my international colleagues from time to time. So digitalization, so digital is one of the big topics for McKinsey, of course. And then I'm always asked to digitize German hospitals, which is not that easy if you know the reality of German hospitals. And that's why the hospital of the future, the hospital 2020, or maybe knowing the speed of the change in the system, maybe the hospital 2030, is different from my perspective. It's all about process innovation. You need to rethink processes. And that is happening already in hospitals in Western Europe, and the speed of this change will increase over time. Why is that the case? Because we do have a big driver for this. We do have the need for more transparency, and already more transparency coming in the system. There's more data available. You get with different technological approaches, you get more data. The payers are asking for more quality because they have more transparency already and asking for even more quality. And more importantly, patients are asking for more quality or put it from a patient's perspective for more patient experience. Meaning not only output quality but quality of the processes in a hospital. And that is something that will present a fundamental change over the next 10 to 15 years, and that is something where we are only in the beginning right now. mean, how does a hospital 2020 look like? From my perspective, there is not one type of hospital of the future we are talking about, but a variety of different solutions. And there are a couple of developments, a couple of trends going on already, and at this point, which we need to look at, to define what is the hospital of the future. The one thing is that you have a consolidation trend in hospitals, not only Germany, or globally. And one driver, so one of my favorite numbers on that is that in Germany we still have 8 hospital beds per 1,000 inhabitants. In the UK, in the US, we only have 3 hospital beds per 1,000 inhabitants. This number alone tells you how that this process will be driven by sheer necessity of that. And there are other drivers maybe on that. So that's why we will have a consolidation. We will lose smaller hospitals and get bigger centers. And that Chris talked about that already. So the second trend is that we will have more outsourcing in hospitals. We already saw that for non-medical processes so far. So like laundry, for instance, outsourced in many hospitals already. But if you think that through, there will be outsourcing for other, even clinical solutions. We see that, for instance, already for catheter labs. But you can basically outsource all clinical solutions. That in the end, if you think that through to the end, you have a hospital that is just a brand, operating without own processes, but have every specialized processes as a shop-in-shop solution in-house. So that's another trend. Then we do have a consolidation in the industry where we find that players integrated not only hospitals but also payers, that you find integrated solutions that insurance services and actual patient services and other services are offered under one roof with the same process structure. That's another main driver. And we do see network formation where you have tiered hospitals in one network. You have basic care you have medium care and you have maximum care in one system, where you even have new business solutions where you sell innovative processes to other players within the same network, which is also an interesting solution that you're not only talking about quality of patient outcome, but also quality of processes. And finally, and maybe last not least in this forum, there's also digital that is coming in hospitals, but digital is not as a self-purpose, but as a contributing factor for more patient experience and for more quality outcome in hospitals. And based on these trends, you will find different hospitals in 10 to 15 years, and you will have no longer smaller hospitals with no specialization, with no quality in-house, but larger centers that can address all of that. And and how we get there, that needs to be discussed probably in more detail.
So Chris, I changed my mind. You get your 5 minutes. Come on.
No, I already hit 30.
No, go ahead.
Oh.
A few words.
I was enjoying these 2 presentations. I work with a lot of nephrologists, and gain conditions, how is it changing, whether it's electronic. For what it's worth, we interface a lot with McKinsey, and we actually are just bringing McKinsey on to help us rationalize some of the change we're going through. So, we are centuries old. Our system is centuries old hospitals. Thinking through what the systems will be, it's like what I was saying, even in my little area of partners. Thinking through the optimal way to deliver using new technologies and the grouping of services that will matter is difficult. And hopefully our friends from McKinsey will help us get there. We're just starting that, but that's. I think we are representative of many large academic centers. Great strength, as I mentioned, but designing our offerings in a way that are most efficient, provide the greatest value, and are most accessible to patients is key. And I'll just throw out an interesting thing for us. We represent about 25% of the healthcare market in Massachusetts, the hospital market. And in this new world of population health, in the US and in Massachusetts, it's the relationship with cohorts of patients that will really matter. So we have to think about that and think about our footprint. So we're in the middle of launching more than a dozen urgent care centers to be able to basically bring care to these groups of people in the environment that they live in a lower cost setting, and keep them, out of our very high cost emergent facilities that are in the main campus. So that's a quick further snapshot on life with us.
You will have another chance. So people wonder why I started pushing people up and down the podium. And the reason is that during our rehearsal, and we had a few of them, we decided that some of us are going to be the buyers. Everybody talks highly about innovation, adoption, and procurement, right? So at the end of the day, someone has to buy and someone wants to sell. So the way we structured it is the three on the left are supposedly the buyers, and then Harrison and Tobias are trying to sell them new concepts that when we come to 2020, we are in good shape to talk about the future. And the reason why we have Harald as number 6 is because someone has to pay for it. So he will explain what it takes to convince them to participate. And by the way, Michelle was kind enough to come back, because this morning I listened very carefully to you, and it sounded quite simple for you. So I suggest that once you hear what people have to say, that you volunteer to help in lubricating the process so that we get there. Okay, thank you. All right, so in terms of the first seller, Harrison, to you.
Thank you. So I would say, trying to sum up everything you could say in 5 minutes is nearly impossible, so I'll try to stick with some use case. But what we're really talking about is a digital transformation of healthcare from where it is today to something that probably will be hardly recognizable in 5 to 10 years. And what we have is a situation where providers today are already starting to feel the effects of drowning in data. And we hear that people struggle. How do you make use of the data you have? How do you actually turn this into actionable insights and make this useful for providers to actually improve healthcare outcomes? And so providers have to be prepared for the fact that with the digital transformation, that data increase is going up so quickly that you have enormous pressure in the landscape to actually adopt your practices to make use of increasing data. So if you look at the provider environment, in the US, the meaningful use rules have pushed providers to adopt healthcare information technology quite quickly in the last 10 years, and most providers you probably talk to would say that yes, it's better than paper, but there's a huge barrier to providing quality care. They're wrapped up with a lot of what they feel is useless documentation and capturing data in electronic systems that really takes away from their ability to treat patients the way that they would like to treat them. So we have to go from the status of having physicians and practitioners who are struggling with computerization of this data documentation burdens to a world where they can turn that data into useful tools to actually increase their ability to improve outcomes for their patients and improve patient happiness and satisfaction. And another huge piece of that will be the fact that as patients become active participants in their health care and in their health, making sure that they actually have access to their records, but going beyond that to say that they need to be able to be active contributors to their healthcare data is going to be critical. So patients will begin to have a big role in providing data to the healthcare system and to their practitioners. And by focusing on that, you can actually say that you now have tools available to clinicians to tap into these data streams to improve how they actually treat their patients by not just looking at the point data when that person comes in for visits, but a continuous stream of their health data across time, so that you can now collect wearables data, at-home monitoring devices, and tie that into the data that they produce when they show up at the hospital point of care or at their practice point of care to really make a difference in how that patient's outcomes and treatments. So what we see is that the amount of data increasing at the clinical point of care is going to be immense. And when you start to combine that with the 2 terabytes plus data per patient for genomics data, you have an enormous amount of opportunity to take that and transform the way that clinicians actively treat patients at the point of care by tapping into that. In addition, you have now the chance for a rapid transformation in how clinicians adopt evidence-based medicine, because now you can rapidly look at the outcomes measures in real time for patients and start to actually get a handle on how different treatments, different trials are performing much more quickly than in the past, and clinicians should be able to tap into that to translate this evidence-based medicine into practice much more quickly. So I had a recent conversation with SAP's chief medical officer about this and a professor from Stanford, and they were saying, it used to be that it would take 10 years for something that would show up in the medical literature to become standard practice, maybe in the point of care. And I think now that you'll see all of this information and the assisted ability to take that information and transform it into useful information at the point of care to assist physicians and clinicians will help to make that process of adopting evidence-based medicine much, much faster. And organizations that can adapt to this changing environment and put those tools in the hands of their clinicians will have a huge advantage in the future.
Your turn, Tobias.
Thanks. My perspective on the question, what about healthcare delivery in 2020, is my job actually at Helios Clinic. Helios is a hospital provider, hospital group in Germany, private group with 112 hospitals. My job is actually to help to close the digital gap of hospitals and patients and the family members. And I try to give you a split answer to the question, what's about the future? Because the first answer is the future is already here. So the major group of the hospitals just go there and they will deliver healthcare exactly in 2020 the way they do today. Because change is really a challenge in hospitals, and I think it's going to take a long time for them to keep up to the challenges of digitization. And there's a second group, and I hope we are part of the second group of these hospitals. We see a dramatic challenge for us. In the morning we saw all the activities of Google and other players. I think this is not only a question of change within the healthcare industry, but there are strong players coming from other industries. And what we did is we set up this e-health accelerator, and we started cooperations with young entrepreneurs and founders, because the existing healthcare IT providers, they're brilliant, they help us to digitize all the data we have in our business, but they lack of the ability to develop tools from the user's perspective. So usability and user's experience is simply not a given ability, and this is why we have to foster the opportunity to cooperate with young founders and entrepreneurs. And it's really overwhelming to see the reaction to our offerings, and we started cooperation with 10 startups right now, and there will be more. And the future is that we want to test specific tools that really address specific problems, as you mentioned for your indication of patients, starting from at the time before people come to the hospital, during the hospital stay. Patient engagement is really key for a better outcome, adherence, medication, and so on. So I think along the whole patient journey, there's so many little tools that may not be as a whole the answer for the future e-health, but if you just collect these different tools along a patient journey, then I think it's a very good starting point for addressing the challenge of digitization. So this is one step. We start to test specific tools at one specific clinic, and then the next thing, we start to set up an IHE communication service to scale it through the whole group, and we will offer an open API to founders so that we can cooperate and tackle the problem of interoperability. And I think the answer is we try to be part of the second group of hospitals. And I think there will be a very broad spectrum of digital offerings, and it will result, I think, we are convinced that this will result in a competitive advantage driven by a better outcome or the perception of quality and service of our patients, and this will remain a competitive advantage, which is really necessary because the competition is very, very high between German hospitals. That's what we do.
So, Tobias, just to build on your description, I want to ask you, Michelle, a question, if you don't mind. So, based on my own experience, this is of last 10 years, selling to Chris is relatively easy because he is very entrepreneurial. He gets it. He understands why the world goes in the direction of digitation. It's all good. Where I find it to be very challenging is when we need to convince the chief innovation officers of the hospitals, the CIOs. They are not really incentivized to adopt new technologies. And I can tell you that 7 years ago, I was totally naive when I started a company called VitalHub. We were convinced that we can run a hospital on a tablet. Very easy. And then we went to venture capitalists, and they all told us, well, where's the data? Where's the pilot? Where's the evidence? And so, even though it's easy to sell to Chris, what do I do about the CIO?
Yeah, it is
For
actually...
a lot of people who don't know who he is, introduce
Yeah,
yourself.
sorry, my name is Michelle. I'm a VC. I invest in digital healthcare. So, yes, you're right. It is easy selling to Chris. I've introduced him to two of my companies today. So he's the soft underbelly of healthcare innovation that we can easily access.
And he's from Boston.
He's from Boston, and he's a convert. He has come to our side. He's on this side. I think that there are a couple of challenges. When I started medical school in the 80s, we just used to do things. We should just do treatment. And in about the 90s, they started talking about evidence-based medicine. So the light bulb to people, anyone who's not in healthcare. So for all this along, you're doing non-evidence-based medicine, and that's actually true. So there wasn't this kind of drive towards evidence, and a lot of that is now driven towards outcomes. And what we have missed in that whole thing is patient experience. So what tends to happen a lot when you speak to chief innovation officers of hospitals or to physicians is that they're focused very much on outcomes, and those outcomes tend to be the outcomes that they like. And it is rarely that the patients are allowed to choose their outcomes. So, not everybody wants to extend their lives by 6 months if there is an adverse effect to a particular drug, but physicians would recommend that. And in fact, what has been shown is that physicians tend to recommend drugs to patients that they themselves would never take. So there is this whole, until healthcare systems start seeing the patient journey as an amalgamation of outcome and experience, I think we will have a challenge. And people will vote with their feet to where they have better experiences. And I think that's something which is never counted. It is never counted in any way when you try and sell cost effectiveness of a tool. The second thing I find very challenging when dealing with that is that you account for the time of the physician, you account for the time of the nurses, you account for the time of everyone, but you don't account for the time of the patient. So there are two possible interventions. One of them involves getting the patient to wait for 2 hours in a waiting room while you do something else. That time is counted as zero, and I would argue that in a national setup, for example, that should not count towards zero. It should count towards the time of a patient, and that's valuable. Especially if the patient doesn't have much longer to live, I think it should be valued much more than the time of a physician. And the third thing that also goes wrong is that, this is a mistake entrepreneurs make, which is that they will come to me and say, I have this tool, if you stick it to everyone's chest, you can save $1 billion. And you say, okay, show me how you save $1 billion. It turns out that you save $1 billion because you're preventing a lot of interventions down the chain. But it turns out that those interventions are costed in fixed cost of hospital buildings and physicians who you've hired, which no one is willing to fire. right? So what will happen is that you will end up sticking this to people's chests and not have interventions and still have the cost of the buildings and the people. So sometimes entrepreneurs are not really focusing on will it actually save costs or will it actually double the cost? So sorry if I went on too long.
So bottom line is that if we entrepreneurs come up with a rational approach, Vishal will invest in us.
Absolutely.
Thank you very much for that. So I come from Canada, from the province of Ontario, where we have only one central system. The government is essentially HMO. It's $50 billion burden on the economy of Ontario. And I spoke to the Minister of Health the other day, and he says, every day someone comes to me with a new great idea about something attached to the chest. And I have no way determining which of them is going to save something of the $50 billion burden. So I couldn't bring the Minister of Health to this podium, but I did bring Harald, who has something to say about how the reimbursement system thinks about it. Go.
Yeah. First of all, I would like to introduce the AOK Nordost to you, which is a statutory health insurer covering the northeast of Germany, including the three states of Berlin, Brandenburg and Mecklenburg-Vorpommern, and which is organized as a public body. And as working on this public body, I have been asked to say something in general about hospitals 2020. Say something in general about hospitals 2020. Okay, I thought to myself, even though the future is open, I will try to take a candle and look into it by making some remarks and questions. So I had the idea to have the next 55 minutes to make some remarks and questions, as we have seen that one of our measures to save money is to talk long and wide about every solution, and therefore you will be trained after this. First remark, we should have in mind that there's not the one and only hospital, not the one and only hospital type, nor the only one production function for hospitals. Therefore, we should beware of two general judgments. The better way would to be differentiate, for example, by country, by region, by payment system, or general speaking, by culture. Regarding this aspect, my remarks are, of course, steered by a German perspective. I hope it would be okay for you coming from somewhere in the world. Second remark, we always have to remember the increasing number of older people and the increasing life expectancy, at least in several parts of the world. But it rests a question to be answered. Does this development lead to a greater volume of demand or only to structural shifts in demand? And to which degree individuals and society are willing to pay for? Third remark, hopefully in the near future there will be an electronic patient file. The already pronunciation is difficult for me because we have about 10 years and 1 billion euros we have paid for, let's say, nothing. Yeah, that's the German experience of how to be efficient. Hopefully there will be this electronic patient file which will significantly will fill the ditch between outpatient and inpatient care. And that seems to me a very well-sounded perspective, a well-sounded trend description into the future. Perhaps this solution will not come out of servers, but out of clouds. And that would be another great shift we have to do in Germany if we think about that solution than the solution of the last years. As fourth remark, as much as possible outpatient care and as much as necessary inpatient care might be a description for the best patient care as well as for the most efficient way of care. Therefore, I guess that hospitals shall, must and will go ambulant. Probably this will depend on some aspects. Deadly diseases will cause another structure than chronic diseases. seldom or often illnesses will differ to widespread popular diseases, and rural situations will lead to other solutions than urban situations. Fifth remarks, perhaps the kind of intervention in stationary will shift reimbursement, which depends at least to a part on the quality of diagnosis, and the result of an intervention will dim too much surgery and enforce a more propitiate, perhaps a more conservative therapy. Sixth remark, the involvement of patients will increase by recognizing that health is co-production at least of healer and patient, forcing the hospitals to take care of their patients after the inpatient stay, perhaps for a long, long time. Seventh, transparency of the hospitals will increase concerning each service and nearly each stage of the hospital production function. And transparency means transparent at every moment to everyone who is interested in this hospital, because of he is a consumer of these hospitals. And I would think it would be a great shift, at least to German hospitals. Last and eighth remark, in saying all this, I thought to myself, will this happen altogether until 2020? Therefore I come to the same perspective, or at least a great degree of covering the same perspective as Sören does it, because we have to have in mind that there will be a lot of restructuring, and not the only answer will be let's say, digitalization of the world. We have to deal with people, and we have to deal with, let's say, analogous forms of illnesses.
Thank you for that. So, okay. So, in my plan, it was a bit ambitious because I wanted us to talk about three topics that will certainly be important as we move towards 2020. One is addressing the situation with the aging population. The other one is everybody talks about, now we call it precision medicine, we used to call it personal medicine, and last but not least, the element of privacy, because together with e-health, along e-health goes the whole aspect of big data. So I will have to leave aging and precision medicine for next year. I want each of you to comment on what I believe to be a serious burden to implementation of all these great ideas, which is the element of being able to protect privacy of information. You want to take it first?
So we had to address this in our proposal and our work, and we are actually working on this. And I think this is, of course, very crucial. And Germany, I think, has a very strict data protection laws, and of course, many people say this is bad. But on the other hand, I think maybe this is also somewhat a challenge for the future. And then, if we can make it, then we have a template for other countries to show that it is possible in Germany, and then we can sell this idea. And our idea is that, first of all, the patient has, of course, to have the he has to consent and to give different keys to different doctors and rights to doctors, which doctor can use which data or whatever. So this is a very key element, that the patient decides who gets which data. The second is that the data have to be somewhere, and in the cloud or whatever. But I think this is a very important issue, and this is that in our concept we say Charité is a data custodian, and the Charité firewall is kind of is prone to be trustworthy. Our data protection at Charité Hospital or at other hospitals are trustworthy. People don't want to have data at AOK. There was some months ago, there was an idea from someone from health insurance company, we make a data custodian, and of course people were very reluctant to this. People don't want to have data at other companies. So I think this idea of this data custodian at a trustworthy data center is very important. And last but not least, of course, I think also data protection is key, and you need to have all the technicals end-to-end and so on. But the other end is that patients who are chronically ill have a different view on data protection and privacy. They want to have treatment and they want to have a benefit from this. And they don't care about if you have a life expectancy with cancer for 3 months or so, you give a shit on this kind of data protection. You want to have some benefit from this. When you enter the hospital, that the doctor has immediately access to your data and have better service. And this is what you care about, and you're not caring about eventually data protection, I don't know, in the long-term future. So this is, I think, very key, that the patient decides who has the data, and the patient decides on the quality and the severity of the data protection. And again, I think patients have a different view on this, and they want to have a cure and not a data protection.
Anybody else?
Actually, McKinsey's written some interesting things on this. I would just say, speaking for myself, not for my employer, but 2 things. One, you've got a fundamental conflict. If a patient were to derive all their care from one place, I think you could drive security to a higher level. But the truth is, the patient lives their life, and their data, just like their own existence, is portable. And those 2 things are in conflict. And I think in the U.S., there is a cultural awareness building that there will never be perfect sanctity, perfect security for the data. And for people to, again, I'm speaking for myself, I think if you look at, one of the vendors makes a system you can see real time where you're under attack from, and my old employer, my current employer, it is scary how many countries are trying to break down the firewall of just any provider. Very valuable data, and you look at security in other categories. I think it's not being truthful with patients to try to suggest that there is impenetrable level of security, because it's just not the case.
So we already tweeted to your employer, Chris. He knows everything you think about it. To you, Harald.
Yeah, saying that privacy and especially the autonomy of the patient will be the very, very question. And of course, there will be attending to, if you are threatened by a life-threatening illness, he will give you data away and follow you. But on the other hand, in the normal case, let's say a chronic patient, there should be the question, to whom will I give my data? And therefore, there seem to be another difficulty coming to the real existing difficulties. In German, maybe it's other way around all over the world, but in Germany, it's a problem to communicate from one physician to the other physician correctly. And that's not only a technical question, but it's an ability to deal with all these letters of doctors and so on. Therefore, this complication will add it with another complication if I, as an autonomous person, say, let's say about 50% of my relevant data I will open to each physician, but the last 50% I will not give to anyone. And therefore, there will be another level of the question of integration of service deliverance, and the question is answered, let's say, about 40 years, 50 years, by sampling this data in the hand of an insurer as a public body. He already integrates all this data. Very trustful and very, very stable.
So since I negotiated with John only 7 minutes, so quickly, there's more to do. So maybe just quick comment for you and from Tobias, and then we'll take one question from the audience. 3, but I need to make a final remark. So, go ahead.
Just a short comment. I agree with everything that was said on the topic already. But I mean, so from my perspective, this debate is sometimes a bit too emotional. And one of the success factors is to make it more fact-based. and once you discuss, concrete facts that are for clear and concrete solutions, it's maybe a bit easier to lead this debate to a success in the end. That's one thing. And the other thing is, we are also, to a certain extent, driven by the patients again, because there is the demand to have more services based on data available. And if you see, there is again, to the debate, if you see the data that is already available today on social networks, there is then a certain mismatch today between the discussion we are leading about data in healthcare and the data that's already available on the internet or open public platforms.
Okay, Tobias, quick.
It's just, I just want to encourage everyone just to get started, because privacy is demanding, but it's just a set of regulations you have to address actually. The privacy regulators simply say it must be patient-centered, you need a consent, and then it must be at least the minimum standard of security is online banking. That's it. There are existing tools, just get started. It's not a question of who could and who should and who would. It's just start trying out understand the patient experience. Start with a small group and not a top-down system for everyone. Then you will never get any practical experience.
Totally agree. So, two questions from the audience. You go first.
My name is Alpha. Before I had a question. What we do, we digitalize the patient journey process. Our target is to improve the patient experience and to bring him closer to the hospital as well, representing the hospital side. 2 days ago I was at HIMSS event in Austria where several hospitals presented they have improved the patient journey process inside, and they had savings of 2-digit numbers of certain departments because they became more effective. So I came back here to Berlin, and one of the first things I heard in the morning, you digitalize stuff for the hospital. Oh, who's going to pay for that? Come on. Hospitals report, there are some hospitals, they report they save on that, on digitalization, improving patient journey process. Plus, I had the experience where the huge insurance company, BKK, came to us with this, as we are doing now. They said, can you provide us information? Which one is the better hospital, which one is the worst hospital? I'm actually representing more the hospital side, and I'm not going to share this information. However, there are players, and they will actually punish the hospitals which are not in the digital age, where patients will be unhappy with them. So sooner or later, not digitalized hospital will lose. What is your opinion on that?
Keep penalizing them.
So I think digitalization per se does not make a hospital more cost effective. I think this is quite very clear. It is a process, and McKinsey can comment on this, and they pointed out the interfaces between the different departments and so on, they have to work, and this is, you can maybe get it better by digital, but digital per se does not make a hospital more cost effective. You have to have the interfaces working and this kind of system working, and in Hamburg, Eppendorf, which is the only hospital in Germany which is completely digital, they saved the revenues, the 2-digit numbers revenues they saved, but before they introduced the all digital health record in Hamburg-Eppendorf, because they made the interfaces more cost effective and more better working.
Yeah, completely agree on that as well. I'm with you. I'm also thinking the hospital of the future will be digitized. There will have many digital solutions and everything. But still we are in a transition phase today. And the reality today is different. If I discuss with CEOs of hospitals today, it's indeed very hard to sell. Very simple digital solutions due to the fact you just mentioned. And that's why we went through the exercise recently. To actually calculate mini business cases for a couple of standard app solutions or other digital solutions for hospitals. And if you really do that, you see today it's very hard to prove that when you have today really a business case for an app solution or a digital solution in a hospital, if you do not include a broader environment of the hospital, and in a fragmented reimbursement system, then you come to the problem.
I would just add, the reorganization of the mode of delivering care, I think Klemens and Sören both touched on it. real world for us, we're spending $1.2 billion to implement Epic across partners right now. But if you drill into that, only a fraction of that is electronically oriented. We're taking our formulary, just one commonly used drug from 42 different variations of the drug administered across our system, now down to half a dozen. So not a lot of electronics there, but it's redesigning how care to better adapt to the electronics.
Okay, one last question from the audience. Go ahead.
So there still seems to be a lot of conversation around what do hospitals do, right? Like how do we improve the mainframe? I think it's fair to say that every patient, or a lot of patients, and myself in particular, are very frustrated with what the mainframe has to provide. Could you comment on whether you think the innovation is going to come from within the hospital systems, or do you think that there are players who might provide services to the patients, and it's going to be the patients who are going to be pushing the hospitals rather than the other way around?
Who takes it?
Yeah, I guess you have made a very, very important point, because patients have been given by this small unit wonderful power, and they will integrate via iPhone or whatever they use all these services. And if you have enough information about what your doctor is telling you, you can verify, you can improve it, and you can see how your way through the system will be. And therefore, this mighty power will not especially come from the hospitals or from some players in the system, but it will come from people like these persons on my left side, which produce more information in the hand of the patient. And because of this, anticipating this development, the AOK is working together with some startups, for example, Jury, which is an application built by people suffering from bulimia, from nutrition problems. We introduced Mujim and general practitioners' daily work to detect depression, something like that, and so on. And the AOK as a whole works together with Cisco on a patient file. So you're right, this development will come to an enormous amount from outside the system.
Iris, quickly.
And I would just add, once patients are empowered to really own and have ownership over their longitudinal health record, they'll be able to really push, I think, providers that they go to use that data to really help them improve their health care, because they won't want to be sitting on their health data if they have a real health issue and not having it be put to productive use. So I think you will see patients really working closely with their healthcare providers to say, I have this data that I'm tracking at home, why not use my activity tracker and my heart rate monitor, and you can start to help me predict when I'm going to have health conditions before I have to end up in the emergency room or in the doctor's office.
Okay, wonderful. So we have to run to the end. Just as a finale, 20 years ago, we used to talk about 2020, and it looked like eons away, right? Guess what, folks? It's only 4 years away. So each of you, just in one word, hold your crystal ball. Chris, it's not your crystal ball. Hold your crystal ball and tell us, you come back in 4 years, what will you tell us has happened in your system?
Work. Our system will work.
Okay?
The patient has moved to the middle of the system.
Predictive analytics will drive care in a much larger way than it is today.
Yeah, patient-centric world.
Tobias.
An amazing split of losers and winners in this game.
In Germany, too less has been done.
All right. So a round of applause to this wonderful discipline panel. Thank you so much.